my great pleasure to address you today. Thank you for attending our session. I'm going to talk to you today about an emerging concept, video-assisted micrographic surgery. By way of disclosure, I incorporated a startup company, which at this point is free of value, but in all disclosure, it is intended to commercialize the technology that I'm speaking to you about today. And I'm the inventor on the patents, so therefore it's another disclosure. And as far as the technology itself, it's not been yet evaluated by the FDA, nor has been proven effective. But I'd like to introduce you to this concept, video-assisted micrographic surgery. And this comes from the world of engineering. As a biophotonic engineer, I put together puzzle pieces that are lenses, lasers, and photodetectors to form novel imaging systems. Visual sensory information can guide the surgical excision of cancer, but there is a healthcare need to make the technology faster, cheaper, and more precise. The gold standard is conventional H&E histopathology. And in Mohs surgery of the skin, this is for non-melanoma skin cancers, that consists of excising a lesion from the patient, placing that lesion on a piece of paper with some notes that then get transported to a histology lab nearby, at which the sample is physically sectioned and a microscope is brought in, and the surgeon, who is in this case the pathologist, looks through the microscope, sees an image, and determines whether there is residual tumor in the margin, thereby indicating a further surgical stage. Well, VAMS has the potential to make this process much shorter, and that's actually a confocal image on the bottom. That is not a histological image, but one that may be produced in as little as a minute by the bedside. And so, in addition to the improved patient experience by shortening this, there is also, since this image is by its nature digital, this ability to do telemedicine with it. So thereby, the consensus of a community may lead to improved outcomes. Okay? So, to jump back and tell the story from the beginning, I created a microscope in 2008 that was a development off of a previous design. And this microscope provided really bright contrast to the nuclei. They jumped off the image like stars in the night sky. And that contrast of the nuclei to the dermis was considerably improved over the previous technology. And you can see that, so it's nuclei to dermal contrast. Here's another example. If you wanted to find the tumor A compared to the background B, that's the metric, it's contrast. And you can see if you were trying to find this tumor on that background, it would be more difficult than finding this tumor on that background. And these are nodular tumors. Now imagine a infiltrative or sclerosing basal cell carcinoma that's just a needle in a haystack. Really bright needle on a really dark background. Okay, so now armed with this contrast, let's look at a Mohs stage. This is a Mohs surgical stage, and this is a big piece of tissue now, imaged rapidly. And we can see if we zoom into the native 30x resolution, the cellular morphology of the epidermis, which is this nice cobblestone road pattern, the eccrine gland, this kind of snaking coil, eccrine gland, sebaceous gland produces the sebum in your skin, and there's the tumor. It's a basal cell carcinoma, and the same cellular morphologies that they use in conventional pathology are available in this image. Well, we created a training set which compared the novel imagery to the gold standard histopathology for the purposes of training the MDs on our team to read these novel confocal images. And the question was asked, can you read these images with the same precision that you get from H&E histopathology? And indeed, and this is the first study, so as the technology develops, it will likely improve, but this is already 99%. So then, that was really good news. But what's the difference between invention and innovation? It's the ability to translate. And so there was a problem spreading this technology to the broader medical community because most surgeon N plus 25 had never seen this contrast before. They weren't trained to interpret it. They did not know what they were looking at. So I stepped back and I re-engineered the technology. In addition to this first optical mode that you see, I added a second mode that provided counter contrast, just like H and E. Contrast, counter contrast, contrast, counter contrast, contrast, counter contrast, and voila. So here we have a confocal micrograph, which, you know, in all disclosure, the technology does take a half an hour to get this image right now, but knowing what we know about technology, if it was optimized, could take a minute by the bedside. It circumvents the need for pathological retraining in the community. Therefore, it facilitates the dissemination and is great translational practice to transform, to potentially transform the surgical procedure from the case where the MD has to leave the room because it takes 45 minutes, they got to prepare this slide, to something that could happen right by the bedside. And again, I reiterate, this has not been tested in a wide trial, it's not been proven effective yet. But we hope that it will be able to deliver the same precision in pathology right by the bedside. And towards that end, and of course the principle is that instead of placing a sample on a chuck in a cryostat, you place the sample directly on the microscope and it scans it in. So, in summary, novel imaging methodology, right, uses lasers, mimics the actual contrast mechanisms of H&E, but also mimics the appearance of H&E, which circumvents the need for retraining. Video-assisted micrographic surgery. So, for the future work, we have a system that is under development that is going to be the first intraoperative system, the first system that is not a clunky lab table bench system, but one that we wheel into the clinic and attempt to perform pathological diagnosis on the patient in the clinic. And I'm really looking forward to the future IRB protocol that says if you can, you know, by consenting for this study, you may receive a faster surgery because that's an enhanced patient experience. Not done yet. And of course, a slick graphic user interface where, you know, the surgeon can zoom and pan, and really, the surgeons are the most focused people around, really. Surgeons and astronauts, pretty much, are the ones with the focus. So if you give them a tool, which means they don't need to leave the room, and they can even improve their ability to focus, I think it's a win. It is my hope that it'll be a win-win after conclusive studies have been done. And I might mention that this technology is some pretty cool Star Trek technology, and you can come talk to me about that at the poster later tonight. And finally, I'll mention that it takes a multifaceted, multidisciplinary village to raise a disruptive technology, and that's my acknowledgement of the contributors and the funding sources. Thank you.